Coming to the second part of our agenda is 2-in-1 co-formulation for total control. So what are the indices for holistic choice of insulin therapy? So need of an insulin therapy that offers total control. One is lower hypoglycemia and mealtime flexibility, simple to use simple regimen and convenience of device, better quality of life and cost effectiveness. So all put together require better fasting plasma glucose and postprandial glucose and HbA1c less than 7%. So that is effective glycemic control. So is insulin Degludec Aspart a prudent choice? Yes. So coming to insulin Degludec Aspart, Idagasp, a world's only co-formulation insulin available at present. So Idagasp contains short-acting aspart 30% and ultra-long-acting Degludec 70%. So in this co-formulation, insulin Degludec exists as dihexamers and insulin aspart exists in the form of hexamers. The two insulin components do not interact in the solution and the subcutaneous tissue, thereby retaining their individual properties. So combination of quick release prandial insulin with slow release basal insulin is a so IDEC as co-formulation when injected into the subcutaneous space is split into insulin Degludec dihexamers and insulin aspart hexamers. And phenol diffuse quickly and insulin Degludec dihexamers link up via single side chain contacts to form long multi-hexamers. Later, insulin aspart monomers are released into the circulation rapidly, thereby controls the prandial glucose. And later on, zinc diffuses slowly, causing individual insulin Degludec hexamers to disassemble, releasing monomers slowly. The prandial insulin aspart component rapidly absorbs fast onset and short duration glucose lowering action, whereas the basal insulin Degludec component have flat and stable steady state insulin monomers slowly released and gradually dissociated. So once a day insulin Degludec Aspart distinct prandial and basal glucose lowering effects. So when this graph shows the x-axis shows the 0 to 24 hours and y-axis shows the glucose in range. So when insulin Degludec Aspart given in the dose of 0.6 units per kg body weight in 22 patients, the green color shows the basal component and orange color shows the prandial component. See this spike of the glucose rise is maintained by the mealtime control is maintained with the insulin aspart and the flat stable control with the insulin Degludec throughout the 24 hours due to ultra long action of the Degludec. So the ideal patient profiles for Idagasp initiation. One is the uncontrolled on oral anti-diabetic drugs. They need insulin for safety and flexibility at the initiation. And the uncontrolled on basal insulin, those who are already using insulin, basal insulin, but still having uncontrolled blood sugars, they have to be shifted to the insulin Degludec Aspart. So their need for flexibility and unacceptable weight gain which is seen with the normal human analogs, and unacceptable hypoglycemia. These two are the main side effects of the human analogs, which are not seen with the novel insulins. So, and the third one is the need for safety. This is safe. Degludec Aspart is safe to use in elderly and frail patients and hepatic impairment, renal impairment, fasting condition, erratic meal patterns. You can use it very safely without having any hypoglycemia and without much weight gain. And coming to the patient profiles for insulin Degludec Aspart initiation. So those who are already on premix insulin once a day or twice a day or basal plus, having poor fasting plasma glucose and need for flexibility and recurrent hypoglycemia. And those are on basal bolus with multiple injections, unacceptable variability and recurrent hypoglycemia and need for flexibility. So these patients should opt for insulin Degludec Aspart. So coming to the efficacy and safety with insulin Degludec Aspart versus once a day basal insulin. This study is conducted for 26 weeks with insulin naive patients with type 2 diabetes mellitus. 296 subjects were selected and 149 patients were put on insulin glargine U100 along with existing OADs, and 147 patients were put on insulin Degludec Aspart along with existing OADs. So there is significantly better postprandial glucose control after a major meal is seen with the Degludec Aspart once a day, which is not seen with the insulin glargine. And there is superior HbA1c reduction of 1.4% is seen with Degludec Aspart, and similar fasting plasma glucose control with is seen with the Degludec Aspart and compared to insulin glargine due to 70% of its basal component insulin Degludec. So with Degludec Aspart, 72% of patients achieve their targets without experiencing hypoglycemia than once a day Iglar U100. Degludec Aspart provided superior long-term glycemic control compared to insulin glargine U100 with a lower risk of hypoglycemia. So the insulin initiation with insulin Degludec, insulin Aspart versus insulin glargine and oral anti-diabetic drugs failure patients with type 2 diabetes mellitus. This is a real world study from the India. The adults with type 2 diabetes mellitus uncontrolled on OADs, patients received Degludec Aspart once a day on one arm, and on other arm patients received insulin glargine U100 once a day, and mean duration was of follow-up was 28.53 weeks plus or minus 19.63 weeks with insulin Degludec Aspart, with insulin glargine 35 weeks plus or minus 25 weeks. And coming to the results, the percentage change in the glycemic parameters and percentage change mean at SEM, there is, when compared with insulin glargine, Degludec Aspart shows a significantly greater glycemic reduction of fasting plasma glucose, postprandial glucose, and the glycosylated hemoglobin versus glargine U100 along with the similar safety profile. And time to treatment intensification, Degludec Aspart versus Iglar U100. Time to treatment intensification, time between the index rate, the date on which HbA1c is more than 7% and existing therapy, and the first prescription for additional anti-hyperglycemic agent dose intensification during the follow-up period. The comparing time to intensification between insulin Degludec, insulin Aspart and insulin glargine, this is a single center experience from India. The time to treatment intensification when compared with the insulin Degludec Aspart and comparator is insulin glargine. 11.65% intensified in the ide-gas group and 11.98 plus or minus 7.81 months with ide-gas needs intensification. Coming to the insulin glargine, 17.34% subjects intensified in the IGLAR U100 group and 6.7 plus or minus 6.86 months with insulin glargine U100 group. So this shows the early intensification is required with the insulin glargine when compared with the insulin Degludec Aspart. Significantly fewer subjects on insulin Degludec Aspart required dose intensification, that is p-value is 0.05, and additionally the time treatment to intensification was significantly longer in subjects on ide-gas as compared to IGLAR U100. P-value is 0.0023, which is statistically significant. This is the real world evidence switching to ide-gas from glargine U100 or U300. This grey color shows the baseline and the green color shows the end of the study. The insulin dose requirements, the significant reductions in basal and total daily insulin dose is seen with ide-gas after 26 weeks of the in this study. The diabetes therapy related quality of life, at baseline only 67.3% have quality of life. At the end of the study, 70.6% of the patients have quality of life. That is significant improvement in total diabetic therapy related quality of life score with ide-gas in patients with HbA1c more or less 7%. Treatment preference. So 74.2% preferred ide-gas to their previous treatment to get quality of life. Switching to ide-gas is associated with a lower total and basal insulin dose requirement and significant improvement in quality of life. So impact on quality of life and treatment preference. This is also a single center survey. Adult T2DM treated with ide-gas, 26 questions were asked in number of subjects 245. 94.2% managed their day-to-day activities better after ide-gas initiation, and 89.8% had improved quality of life with reduction in number of tricks, and 86.7% found it comfortable to inject ide-gas in different social situations. The reduction in the number of injection tricks, flexibility and simplicity of dosing with ide-gas translates into better quality of life. So ide-gas evidence, reduction in pill burden. So reduction in the pill burden with ide-gas initiation. 70% of the patients on 3 OADs could be shifted to 1 or 2 OADs after initiation of ide-gas. 50% on 2 OADs a day were shifted to 1 OAD a day. And reduction in the pill burden with ide-gas initiation, then 13% of patients are on 2 OADs and 47% on 3 OADs and 17% patients are on 4 OADs. Ide-gas evidence, reduction in the pill burden. Reduced pill burden improves quality of life and adherence to treatment in individuals with diabetes. And coming to the cost effectiveness of ide-gas. So yearly total cost of medications and healthcare resources based on the Indian cohort. This is very important. So coming to the all treatments and ide-gas and yearly cost difference, the medication costs usually cost around 51,590, and when coming to ide-gas it is a little bit high, 67,326, and yearly cost difference is 15,734. Coming to the healthcare resources, all treatments 27,737. With Idagas, this was decreased to 9,447 only. The yearly cost difference is 18,690 rupees less cost with Idagas. And coming to the outpatient visits, 13,479 visits with all treatments, which was remarkably decreased with Idagas 5,930, and yearly cost difference makes 7,548 rupees. And emergency room visits are 5,468 with all treatments, and which was decreased to 1,203 with Idagas, and yearly cost difference was 4,265. And inpatient hospitalizations are markedly reduced. In all treatments 7,698 with Idagas 1,847, and cost difference is 5,850 rupees. And work days missed, very important, 1,091 days were missed with all treatments, which is very much less with Idagas. Only 65 days working days are missed, and the yearly cost difference makes 1,025. So total cost 79,329 with all treatments, 76,373 with Idagas, and yearly cost difference makes less than 2,955. So yearly total cost, including that of medication and healthcare resource use, with was lower with Idagas as compared to all treatment by 2,955.83 rupees. The number needed to treat to bring one patient to targets of glycosylated hemoglobin less than 7% and less than predefined individual treatment target was lower with Idagas. This shows the superiority. The Idagas is cost-effective treatment for people with type 2 diabetes not achieving glycemic targets on other therapies in routine clinical practice.